Hi, everyone. Welcome. This is the last session of today. Hopefully, we'll make it interesting. My name is Ben Reis. Thanks for inviting me. I'm going to talk today about the age of predictive mental health. And so, we're going to talk a bit about some wide topics. We've heard some very fascinating talks so far today about AI and its applications in mental health care. What I want to focus on today is using AI to predict mental health outcomes. We heard a bit about it in other talks. I want to make that the focus of this talk. I also want to give kind of a high-level overview, so we'll be able to see some interesting trends that the field is developing. Would love to hear your questions and your thoughts as we go. So imagine you had a crystal ball, kadur bdolach, I think is how you say it. What would you want to predict? So a lot of people, if you ask them on the street, they'd say, oh, I want to predict the stock market or the sports scores. And then you say, okay, well, let's not talk about trying to make a profit. What if you were if you had a crystal ball and it had to do with yourself? What questions would you want to know about your own future, right? So some people immediately jump to, well, how long will I live? Or will I get sick, cancer, God forbid, etc. And so people start asking about their own health. So let me just do a quick poll here, because we're entering the age of predictive medicine. And this is not meant to be a philosophical one. This is more of a gut feeling. Okay, so I'm going to ask it and just say yes or no. You won't be held to it. Who here, if we had a magical way of knowing, your date of deceasement, in other words, how long you will live, right? So who here would want to know today what date they're going to die on? So raise your hand if you'd want to know. Okay. Who here would not want to know it? Okay, majority. Excellent. Okay. So majority do not. That's a common answer. If we had a magical way of knowing if you'd get a major disease, right? So whatever the major chronic diseases that we all know about that often come towards the end of life. So who here would want to know if they are going to get one of these major chronic diseases? Okay, who would not want to know? Okay, so we kind of flipped it around. Okay, if the disease, I'm going to keep changing the scenario. If the disease were preventable, okay, so the question is, you can know whether or not you're going to get a certain disease, but this disease is preventable by you taking action now, right? So it's avoidable. The action is going to take some effort, et cetera, et cetera. So who would want to know about a preventable chronic disease that's actionable now? Okay, who would not want to know? Okay, good. So we've reached unanimity. Okay. Who would want to know, if you have a spouse, who would want to know their spouse's date of death? Okay. Who would not want to know their spouse's date of death? Okay, we have hands raised lower, I think. That was weird. So I'm not sure what that means. Confidence intervals are higher. But again, more people know. Okay. Finally, I'll ask a question. If, let's say you had a child, and if you don't have a child, pretend you have a child. If we had a child, would you want to know if your child was going to have a life-threatening disease, even if it's not preventable? Would you want to know? Okay, and who would not want to know? Interesting. Okay. So we have some different answers here. And the reason some of the hands didn't go all the way up is either you're tired because it's the end of the day, or these are kind of new questions that many of us probably haven't thought about because, with all due respect, we don't have such a crystal ball yet. And even the ones that we do have aren't perfect. But it's the kind of questions we need to start asking ourselves, because as vast amounts of electronic data accumulate of different types in these large databases, and as AI gets better and machine learning gets better, we're getting better at answering these questions. And so we need to start thinking about, do we want to answer these questions, right? Science is very good at how. It's not necessarily good at why or whether. And so I want to show you kind of where we are, where we are now in this field, and some other questions that come up based on today's technology. So as you know, there's a lot of data accumulating in these vast databases. And what I want to start off is with a little quiz. This is a chart of the last 100 years. It's US data. This is basically rates of mortality, so causes of death. And you see 4 lines here. So let's trace the green line, which is tuberculosis. And this chart is normalized. So you see at 1917, a certain amount of people were dying from tuberculosis, and that's put at 100%. So 100% is the normalized number. And over time, we see by about mid-century, tuberculosis we had treatments for it, prevention, et cetera. And today it's near zero. Okay, so that's a nice picture of modern medicine, and we should appreciate that. Same thing with gastritis, right? So people used to die from gastritis, and now, relative terms, they aren't. Influenza and pneumonia, unfortunately, can still impact especially vulnerable elderly. So we still have about 25% of where we were 100 years ago. Okay, so my question is, what's the red line? Heart disease? Depression? What did you say? Cancer? Schizophrenia? Other ideas? The red line, again, I'll just point out, is something that hasn't really changed. It's moved up and down, but we're about where we were 100 years ago as far as the number of people per 100,000 who die from this condition. What did you say? Suicide, correct. So we had someone say depression also and suicide. So the answer is suicide. And when you see this graph, it's unfortunate because modern medicine is supposed to fix things, not keep them the same. And if you look at the last few years, it's unfortunately getting worse in many subsectors of society. So here's some data for the last 20 years or so, and you see suicide rates going up. Different for different age groups, et cetera. And it's not better since the pandemic, as you know, social media. Some people are quick to make the associations there. But suicide is a problem. So I'll talk a bit about our research, but I actually want to spend a bunch of the time in today's talk looking at recent research that's not ours, that's come out in the general field. So starting a bit with our research. So we started looking at suicide a while back. And we said, can we predict suicide based on electronic medical records? And the first answer, when we started talking to clinicians, this is a psychiatrist at Harvard, at Mass General Hospital, and they're like, well, we're happy to let you try, but the answer is no, it's probably not going to work. And then we spoke to psychologists at the Harvard Department of Psychology, including Matthew Knock, who's one of the global experts on suicide. And he's like, yeah, it's probably not going to work because the kind of information that you usually need in order to predict if someone is suicidal is what's going on in their life. Has something happened in their relationship, in their family, in their work? At least that's what Hollywood leads you to think, right? If you see a movie, you think people attempt suicide because something very dramatic happened and they kind of have no way out, etc. So we said, well, let us try. Let's see if we use the most commonly available data. So they said, well, there are all these registries where we have rich data about the person and they filled out questionnaires and surveys. We said, well, that's not useful because then you can't use that as a population level screening tool. We want something we can do with everyone. So most of everyone in the Boston area, let's say, is involved in some sort of health system and they have a electronic medical record. And in America, as you probably know, the payers and providers are usually separate, right? Because Americans' health system is broken in many ways. And so there are these billing codes, which are basically administrative data, ICD codes that go back and forth. Okay. So we said, well, let's look at the most basic level of data. We're not even going to look at the clinician notes. We're just going to look at the ICD codes. And we grouped the ICD codes by various higher level categories. And then we saw, is there any kind of risk associated with suicidal attempts and outcomes? And this chart is actually, it's a Manhattan plot for those familiar with genetics analysis, but this is more of a phenome Manhattan plot. And what you see here are different subgroups of data. Let's see if I can show you my pointer. I don't know if it's visible. Okay, so I'll just walk over here. Okay, so what you see here is basically the full span of human disease in very high level categories. And as expected, a lot of the codes that are related to mental health are showing increased association with suicidal outcomes. And these are various kind of mid-level groupings. But what's interesting here is that we also found some gastrointestinal codes that had significant risk associated with suicide. And that's not on the list, along with things like substance abuse and psych codes. Those people are often already on the radar of suicide risk. But we found codes in other categories that were surprising to the doctors. We also found certain things that officially are protective of suicide. right? So here we have pregnancy-associated codes. You can think speculatively about how if someone is pregnant, she has a lot of people around her, or she has a purpose of living because there's a new life being born. You can think, or if she's pregnant, in most cases, that means there's a family around her and she's less alone. There's a whole bunch of speculative thoughts you can have about why this would be the case. But it's interesting that you actually see, and here you have seen neoplasm. So this is people with cancer. Most cancerous subcategories were actually protective of or associated with lower rates of suicide than those who did not. And that might be because they're older, or they are being treated for cancer, which means they're not alone, which means et cetera, et cetera. So there's a whole bunch of interpretive surround here. But what's interesting is that we see some signals here outside of where most people think the signals would be. And that's important as we moved back to the normal microphone. That's important because this allows us to basically apply this to the entire population. The goal of this tool is not only to take the psychiatric population and see if we can create an enriched subset that says, okay, screen these people for suicidal ideation. Instead, it's, can we look across the entire population and see if people are falling through the cracks? They're not on the radar of the psych services, right? Now, I want to say ahead of time, everyone, especially in the psychiatric and psychological community, was very skeptical about this initially, as we were, because what are you talking about? This is a bunch of numbers, and in order to evaluate someone psychologically in their mental state, you need a human being to do that. So let me say off the bat, we agree with that. We think that computers should not even be clinical decision support systems. We think this is one level before that. This is a screening support system. What does that mean? We don't think a computer looking at some building codes can help a professional, social worker, psychologist, psychiatrist, mental health worker, decide if someone is suicidal. Absolutely not. What we think is, from a health system perspective, we think that many people are not screened as they should be by those professionals. And so the very least what this system can do is, across the general population who are flowing through the health system, identify people who are statistically at high risk, create an enriched sample so that the limited resources of experts that we have can be applied in a more efficient way. So in other words, you have 1 million people, this system can say, or let's say you have 1,000 people going through a hospital a day, and only 100 of them can be screened, or 50 of them can be screened. This can help you pick that, in addition to those who have obvious signals that are going to be screened. So again, it's a system, it's a backstop. It's an attempt to prevent people falling through the cracks. I think you say in Hebrew, lipol ben hakisaot. Okay, so that's what this is. It's an attempt to bring the expert's abilities to bear on those people who might need it most likely to need it. That's what this is. As soon as the expert is involved, this is already silly, right? To say, oh, well, you have this risk score that should influence, right? So this is more about who should see the expert rather than what the expert should say. So it's important to put that up front. Now, the system actually did pretty well. It was able to identify between 1/3 and 1/2 of all suicide cases, on average, 3 years before they took place. Now, we were very excited. We said not only do we have high specificity, high sensitivity, but we also have advanced lead time. And we have actionable data here, because if someone's suicidal, you try to get them seen and be tracked and on the radar of the system. But this is a problem, because when we came running excitedly to the clinical folks that we work with, we say, look, not only can we do this sensitively and specifically, but we can do this 2 or 3 years in advance. They said, oh, well, we don't want to use the system. And we said, why? They're like, what am I supposed to do as a doctor if you tell me that at some point in the next 3 years, this person's going to be suicidal? That sounds like a lawsuit waiting to happen. That's a very American response to it. But also, without the litigious environment of America, it's also a big question. What are you supposed to do with this data? If you have extreme risk for an extremely acute period, you say in the next 24 hours, I think this person should be on suicide watch, then there are actions to be taken. Those are the terms that the clinical system knows how to deal with. And so what we had to do actually to make this useful is they said, can you actually make the system more myopic? Can you just tell us what the 30-day risk is? That's something we can work with, because then we can make decisions. It's obviously a sparser data set. Our signal, it was a bit harder of a machine learning task, because the people who have an episode within 30 days is a much sparser data set than within 3 years. But it was an interesting kind of feedback loop. We did a number of follow-up studies. I'll kind of mention briefly some of them, but we tested it across a whole bunch of different diverse healthcare settings through this network of hospitals, and it was effective in all of them. We looked at it in the Army. We looked at it in a population of people who had been sexually assaulted. We looked at it amongst multiple sclerosis patients because, if you all know, suicide is sometimes seen as elevated in MS patients. We did a bunch of nerdy things, including seeing how we can integrate information from the unstructured data in the doctor's notes with the structured data in the billing data. And then we also did some sort of policy modeling work to understand if this could be cost effective from a resource utilization perspective. We also developed some temporally aware models that kind of grabbed the temporal information, not invented, but let's say modified a new version of random forest models to do that, and then used some landmark models as well. So kind of did a whole bunch of studies around this. What I would say is probably most interesting that came out of this work was the interaction with the clinic. And what we found was that not only did we have to pitch it as a screening support system and not a decision support system, which was, in my mind, the right thing to do, but the communication, the actual text that goes through to the clinician at the point of care is very, very important. So if you say, this person has a 90% risk of suicide in the next 30 days, that sounds very scary, right? Or is high risk, right? There's a stoplight, green, yellow, red. This person is a high risk group, or falls in the top 5% risk category of all patients, right? It sounds very scary. And so what doctors often do, they are very reactive creatures, and they will say, okay, if that's the case, I need to write up a whole bunch of stuff and show that I did the right thing. Because I don't want to be on my watch that I got a very clear message from a computer and I ignored it. Right? And they don't really know, they know how to react to blood tests and lab results and stuff, but they're not sure how to react to computer statistical AI models. How much do I trust it, etc. And so you can get two extreme reactions. And we saw these reactions in the early days of the first kind of computer models that were clinical decision support were in the field of radiology, where people were kind of looking at chest x-rays, mammograms, other radiographic images, and they were trying to figure out, is this a false positive or a false negative? And initially there were kind of two extreme overcompensations that the medical system would do. The first one was, oh, the computer said it, I don't want to be sued, I'll just agree with the computer, even though it was obvious that there was some sort of artifact. Or, wow, this computer's pretty good, I'm going to ignore the computer, I'm going to ignore my own expertise because I'm human and it's easier to just trust a computer. Once I trust the computer, even if it says everything's okay, I won't check to make sure that it didn't miss anything. So you'd have this kind of overcompensation in both cases. If the computer says there's a problem, you agree with it no matter what. And if the computer says there's not a problem, you disagree with it. You also agree with it and you don't check. Now that's obviously very not ideal. Right? On the one hand, you want to make these systems as reliable as possible. On the other hand, you don't want to create this over-reliance. And so we did one thing, and I'll tell you about another thing that I think is also useful. So one thing that we did is in the actual messaging, we had a whole bunch of focus groups, etc. In the actual messaging that comes out of the model when it talks to the doctor at the point of care, we say something like, this patient, according to statistical analysis, falls into the top 3% risk score of all patients. Now that sounds very scary, okay? But then we added another line. Most people who get this alert are not suicidal. Right? And if you want to get even stronger, we say something like 80% of people for whom this alert is shown turn out to be non-suicidal. However, since there's elevated risk here, mandatory suicide screening is recommended, which you're supposed to do with everyone. You don't have time for it, so don't skip it here. Okay? And that line where we say 80% of people who get this alert turn out not to be suicidal relieves the doctor of any sort of pressure to protect themselves. I think the Hebrew word is kastach, right? So this is the anti-kastach line that tries to keep them neutral and using them. Now, there's another, let's say, approach, another model of hybrid computer human interaction that is coming out as AI models are coming into clinical use. And that hybrid model basically says human beings are subject to human nature, including clinicians. And so you don't want them to over-relying on it this way or that way. And so what you do is you have the computer model available, but you have the doctor express an opinion before you show them the computer opinion, right? Now this assumes that the doctor was going to do that anyway, because if it's something they weren't going to do, then they're not going to participate, et cetera. But if something they're going to do and they're supposed to do, and if the computer weren't there, they do it anyway, you make sure that the doctor enters their answer into the system, and that creates an audit trail, okay? Then the computer shows their answer, okay? And then the clinician can change their answer based on the computer. But if they change it, they have to put in a note why, okay? So they have to explain, yeah, the computer saw something I didn't, and it's fine. It's all internal. It's not like against them. But when they know that this is the process, they actually put in some effort, because you don't want to be wrong and the computer got you right, right? And if anybody has a statistically high rate of changing their answer or disagreeing with a computer, they're reviewed because they're saying, okay, clearly you're not filling it in as you should. You're not actually doing it. So that hybrid model seems to be an emerging way to avoid the over-reliance. So I can talk more about suicide work. I want to talk about a few other projects we did and then get into other more recent cool AI stuff. So we're all familiar with psychosis, the kind of broad category of mental health conditions. You're probably also familiar with the idea of, I see there's a typo there, of first episode psychosis, which often happens in late adolescence or early adulthood. And you're probably also familiar with the idea that if psychosis after appearing isn't detected or treated, and it's left undetected or untreated for a while, it can deteriorate to the point where you can't bring the person back to where they were beforehand. And on the other hand, if you catch it early enough, you have a much better chance of the person has a much better prognosis. And so there's something called DUP, which is duration of untreated psychosis. Okay? And the World Health Organization says this should be down to a few months, even though the average is up to a few years. The average is 3 years for the cases that we know about, right? Because a lot of it goes undetected. So the question is, why is it so hard to detect? And the answer is that there's no blood test for it yet, but the person is basically losing touch with reality in various ways. And it often happens in a very, let's say, melodramatic time of life, right? So if your teenager comes home and is acting a bit crazy, they're not psychotic, they're a teenager, right? If someone just moved away from college and it's their first time living alone and they're having kind of overreaction to being invited to a party, not being invited to a party, being scared about their first test, that's called being a college student. It's not bad. And then, so this kind of tumultuous period of life can often mask actual psychotic behavior. And oftentimes the story goes that only after a year or two, when everyone else has calmed down and Jimmy or whoever it is still acting up, do people say, you know what, actually, maybe we're seeing something that's not a temporary drama. And then they go back and say, well, this actually started 2 years ago, and then by then it's deteriorated. So wouldn't it be great if we had a computer system to be able to do it? So this is work that we're about to publish. But basically the answer is yes, we can get up some pretty early detection on the order of months or years, depending on how you're looking at it, of these first episode psychosis patients. And it's based only on the medical record. We did it across multiple sites, different healthcare settings, but there is a signal in there. And this is something that the doctors were very welcoming of, because they say, listen, we can't do anything until someone's brought to us. And there are these, at least in the hospitals that we worked with, there are special kind of units and special doctors' offices that deal with, clinics that deal with evaluating psychosis. And they say the number one problem is that people come to us too late. And so if we had a way of reaching out ahead of time and screening people when the symptoms start, that would help us do our work much better and help them much better. So this, again, ties into a larger theme, which is that a lot of these, there's a lot of data accumulating there. There's a lot of new methods kind of accumulating out there. But we try to focus on actionable intelligence. So we actually, when we started this work in our group, Predictive Medicine Group, we started predicting a whole bunch of different things, including physical conditions, not necessarily mental health conditions. And we said, well, let's look across the entire human diseaseome, as we call it, and see what the computer can predict based on medical records. And what we found was that the computer actually did a good job of predicting a whole bunch of stuff. But then when we added the metric of how much earlier can you predict it than the first diagnosis in the record, we saw that there was a very big difference between mental health conditions and what we call physical ailments. Okay? So for example, diabetes, we had very accurate prediction of diabetes an entire 3 weeks before the diagnosis took place. So okay, are we going to change healthcare if we can identify diabetes at 3 weeks? And there's probably not. There's an A1C, blood test, etc. And so we said, okay, let's focus on things where we can actually make a difference. And then within that, let's focus on things where not only can we do it early enough, there's a delta between what we can do and what doctors can do, but also where someone can actually do something with that information. So obviously suicidality, you want the person to engage with a healthcare provider, see what's going on. Oftentimes they just need someone to reach out or provide a whole bunch of interventions as appropriate. Psychosis, same thing, but it's just not known. So I want to bring up another category within that's related to mental health that we ended up focusing on. This is actually the one we focused on first, but I'm talking about it last. You'll see why in a second. And that is abuse. So abuse, which can take the form of many, many, many different types of abuse, is a tragic topic. We wish there weren't any abuse, but unfortunately it's an iceberg condition, which means that between 80 and 90% of abuse cases are never revealed at all, let alone detected in real time, let alone et cetera, because of all the issues of trauma and stigma and fear, because you're often, this is the very worst kind of problem because it's happening in what's supposed to be your safe haven, and your protector is turning into your abuser. This is with child abuse or spousal abuse. All of it is very, very bad. And these challenges are compounded because, unlike other conditions, abuse usually happens in the home. And because of the social contract where we say, yeah, my home is my castle, I have privacy in the home, we trust parents and we give them the space to raise their family as they want, this usually happens behind those four walls of protection. And those four walls of protection, I think we all agree, we want private, we don't want government cameras in our living rooms, right? But at the same time, those who abuse that social contract and break it and say, well, even though I'm a parent, I'm now going to break that social contract and abuse the child or spouse, etc. It's a terrible thing, but it's hard to detect because of that privacy shield that we all see the benefits of, but also there's dangers lurking there. And so this is a very hard problem, the detection of abuse. And belet brera, not by design, but by expedience, the two groups of people that usually end up detecting abuse. Who do you folks think they are? Teachers, yeah, and who else? Yeah, child abuse, yeah. Who are the two groups of people who usually end up detecting child abuse? Police usually get called in after, unfortunately. See? Yep, nurses and clinicians. So it's basically primary care settings, sometimes emergency settings, and educational settings. Now, when you ask a teacher, why did you go into teaching? He or she will say, I went because I wanted to teach kids. When you ask a pediatrician or a nurse, why did you go into pediatrics? Well, I wanted to help kids, right? And they work on being very good friends with the parents and showing that they are partnered to the parents. And when a father brings his kid who just got injured, on the soccer pitch, what you want to do is you want to be kind and help the father, et cetera, right? So, and the same thing with teachers, right? The entire system is set up in the opposite direction. One of trust, one of caring, and that's a good thing. But when you force teachers and doctors and nurses to say, well, you also have this policing role where you're supposed to detect abuse, which happens behind the four walls of the home, that's a very weird question to ask. It's an important question to ask, and it's an important request, but it's a very difficult one because many of them haven't been trained to do it. Today, there's more training for that. But also, it goes against the very dynamic of the interactions with the kid and with the parents many times. And so there are, even if you say the doctor really wants to learn how to do it and the teacher really wants to do it, there are, let's say, structural barriers to overcome just in the way these institutions work. And also, they are not set up as policing, crime-fighting institutions. They're educational and medical. And so because of all these challenges, abuse continues to be extremely hard to detect, and often if it is detected, it's detected late. Okay. So the question is, can we use these same approaches to detect abuse? Okay, so again, it's looking at the population. It's not just within, we're not looking under the lamppost, if you will. We're not looking under the people who are already under Child Protective Services tracking. We're looking at the entire medical population. So this is some fake data, and we're looking at, everything's been jumbled here, the dates, the data. But this is just an example of, over time, a kid showing up at the emergency room. And you see some very normal stuff like cellulitis, ingestion, who knows what, little random things that kids do. But once you look through it, you'll start seeing a pattern of maybe a bit more bumps and bruises than usual. And so this is already very compressed. Usually to get this much data, you have to scroll through many, many screens. So a doctor who has screaming kids everywhere and is in the emergency room and needs to just get the kids through, and there's otitis media and there's this and that, doesn't have time to go through all the history and can try, but there's no real way to do it. So actually our first paper in this space started here, which is basically using emergency room data and just the billing codes to try to predict this stuff. So we came up with a case definition. This is all very electronic notes based, electronic code based. We developed some naive Bayesian classifiers, which is a very interpretable, very simple machine learning model. And we looked at different, we stratified by sex, by age. So these are different kind of heat maps of risk for men and for women. We looked at kind of different risk scores across men and women. So you see here, this was now in an adult population looking for spousal abuse. There's different studies here, but looking at an adult population for spousal abuse, you see that alcohol, substance-related mental disorders were a higher risk in women. They were rarer in women and therefore indicated a higher risk than they did in men. Same thing for injuries from external causes. There was kind of an 8-fold difference. They were much rarer in women and therefore indicated a higher risk of abuse. And other psychoses you saw that flipped. So affective disorders were actually more indicative. They were rarer in men, at least in the diagnostic record, and therefore indicated things. So that's all these kind of anomaly detection things. We were able to kind of visualize the medical record for the doctor in this kind of summary format by time is on the y-axis and clinical category is on the x-axis. And each line represents a different visit. And the color is how risky that visit, how much risk it contributes to the overall abuse risk. This might look like a gel electrophoresis for those who know the genetics world, so we call this a risk gel, an abuse risk gel. And then we could kind of, the detection would happen after a certain amount of evidence built up. In this study, we were able to detect between 1/3 and 1/2 of all abuse cases, on average 2 years before they happen, and in some cases up to 6 years before they happen. So one of the questions we got was, okay, does that mean you're predicting that abuse will happen? Or are you detecting undetected abuse? Right? So I just want to make that question clear. Is this a prediction of abuse or detection of abuse? The honest answer, if I had to give a technical answer, is we can't tell because we have no gold standard. The realistic answer, it's most likely undetected abuse that would have been detected later and now we're able to catch it a bit earlier, right? Now, you could also say, well, maybe there's a pre-abuse condition. And by pre, I put a pre-abuse in quotes. So have you heard of pre-diabetes? It's basically your body is the homeostasis of your body and the metabolic homeostasis is spiraling down towards a diabetic state. It hasn't officially reached the thresholds necessary to qualify for diabetes, but it's going in a bad direction. And so we'll try to intervene. So maybe there are also pre-abuse states where, statistically speaking, this is something that's starting to happen. Right? This was not my idea. This is something that when we start to talk to psychiatrists about this question, they also said, it's not even just those two categories. Will it happen or is it happening already? Maybe it's already starting to happen but doesn't meet certain criteria, et cetera. So not going to opine on where we are there, but it points to a very important question, which is, what is the gold standard? So oftentimes when you create these machine learning models, you want to train the model on some training data, and then you label the training data with, here's the cases that were abused, and here's the ones that weren't. Now you kind of sniff around for statistical patterns, And as a result of the statistical patterns, you can then make decisions on new cases. This would be ideal. But we have a fundamental problem here. If we assume that 80, 90% of abuse cases are never reported, that means that we're training on the current limitations of the medical system, insofar as they are ascribing a false negative status to a whole bunch of true positives, right? 80% of the abused kids or spouses are not labeled as abused, and therefore we're learning to ignore them, right? Because we can't tell what's a real negative and what's a false negative. And so we're almost teaching the model to replicate the blind spots of the current human doctors. And so this gets into a deeper question, which is assuming we don't now create a police state where there's cameras everywhere and we interview every kid every minute to see who's really abused, which obviously there's a desire to catch every abuse case, but the question is when does it hit some trade-offs and what are the resource limitations? But assuming that this problem continues, which unfortunately looks like it will, that many cases are not detected, and even if we improve awareness, right? Okay, so we get it down to 70% are not detected, but it's still a lot. How can we train models to actually do that? And here we get into some interesting cases. So I want to share some of the experiences we had in this. When we ran the model on some of the training set, there's hundreds of thousands of patients, all anonymized, IRB approved, et cetera. We actually had to create an irreversible anonymization because there's a legal requirement in the state of Massachusetts and many other places that if you suspect abuse for any reasonable cause, you have to fill out a 51A form, file a report. So, and that turned out to be, when we spoke to the IRB, they're like, you're playing with live ammo here, because even if you don't know who the kids are, if it is physically discoverable who these kids are, you have to report it, because that might be a kid who's being abused right now. And we obviously didn't want to be in that position while we don't know if the model works yet, right? So for the development, we didn't want to create any ethical dilemmas. The long-term goal is obviously to create a model that will help, but during the creation of the model, you don't want to, break the law, et cetera. So we had to create physically irreversible anonymization to the data, like destroy the keys, everything, so it does not exist, that we could try to optimize the model. And what we found was that the model, did pretty well. Of the things that were known to be abused, it got a bunch of them, high sensitivity. Of the things that were known to be non-abused, it flagged them appropriately, high specificity. But there were some that got really, really high scores according to the model. But the label that they had on them, according to the medical record, was that they were not abused. So officially, that's a false positive, right? The model generated a high score, but it's wrong. And so what we did is we said, well, we're not going to believe that that's a false, we're not going to accept that that's a false positive without looking at it. And we pulled the highest, again, all anonymized, but just looking at the data, we pulled the highest scoring individuals and tried to see, is there any commonalities to this kind of cases? And we looked across hundreds of them and saw that there were certain patterns there that the computer was catching, but that are often missed by doctors. Now, just you remember, the model was based on what doctors catch. But since it's such a rare condition, doctors don't catch all those cases. And so what the model was able to do, it was able to expand the lamppost, let's say. You know this expression, to search under the lamppost, the chapes tachat hapanas? So we weren't looking kilometers away from the panas. We were making the panas, the lamppost, a bit wider. Because these are things that maybe are caught 10% of the time, 20% of the time doctors, and then we use that to expand, say, okay, let's find all the ones similar to those. And so we're able to expand the circle. How about the ones that are very different from the ones that are caught by doctors? That's a different question. That's a harder challenge. But even within this limitation, we're able to kind of mitigate these effects somehow. The reason I'm kind of drilling down on this is that this is a big problem in any predictive medicine setting, is your training data is going to be imperfect. Okay, so now that was the stuff that kind of we had done. There's more ethical dilemmas we can discuss. What I want to do is maybe take 5 minutes now to show you cool projects in the field, not related to us, that are happening in AI. Some of this work was described, or similar work was described earlier this morning, but this is more kind of a state of the field. So in order to tell you what are the issues people are working on now with LLMs and AI in this predictive capacity. So A lot of people are actually implementing these child abuse systems. The field has grown since we published the first paper. There's a lot of very good people in the field now, a lot of systems. This is an example in Pittsburgh where they actually implemented the system. There's now people doing evaluations of, what are the problems, what are the key challenges, and again, the false positives that we discussed. And then they've actually had kind of these consensus symposia where they come up with what are the best ways to implement these in practices, and a lot of the issues that we discussed come up. But here's what I wanted to show you. Explainability. When you come up to a doctor, especially someone who's an expert in their field, and you say, you're a psychiatrist, and we have this machine which can tell you, can detect things you can't. There's not only maybe an ego issue, but there's a genuine doubt of how can you? That's ridiculous, right? And so doctors end up believing AI systems if the AI systems can explain themselves. So there's more and more papers coming out in the last few years. This paper was very interesting. It basically compared a black box AI model, which is very powerful, one of these big LLMs or various other black box models, with an explainable model that can actually tell you why it's thinking what it's thinking. And it turns out, as expected, the black box model actually performed better against whatever silver standard they were doing. But even though the black box model got better numbers, it got worse reception by the doctors because it wasn't able to deliver an explanation. And so doctors ignored it in practice. But the simpler model that was more interpretable and explainable did worse on the numbers in the lab, but did better in the field and actually had more impact because the doctors could understand what it was saying. So when people in the lab are optimizing for numbers, you should remember the ultimate number you need to optimize for is impact. Here's a meta study of that same thing. They looked at 10 studies that looked at this question, and of the 10 studies, 5 reported that explainable AI increased clinicians' trust, particularly when it was clear, concise, and relevant to the clinical practice. But 2 studies highlighted that explainable AI could either enhance or diminish trust depending on how complex and coherent the explanations were. So it's not even enough for the model to explain something. It needs to get to the point and be very clear. So this is an active field now. And it again highlights the point of you can get some really cool results in a lab on your bench top or on your desktop. But once you get to the bedside, a whole slew of factors are there, including the psychology of the doctor, the clinical workflow. And this kind of stuff ends up being the most important because all the little adjustments you made to your AUC are no longer relevant. And now final section, this is kind of the cool neato things going on. A lot of people are talking about how AI is advancing and the power of AI to do things that it couldn't before. And that's really a transformative thing, especially in natural language with LLMs. But what fewer people are talking about is the alternative data sources that are now being utilized. And we saw a bit of it in the other talks that we heard today. But this is, in my mind, where a lot of the exciting innovation can happen. Because you all know the expression garbage in, garbage out. So even if you have a really, really good garbage compactor, it's still garbage out. Okay, so LLMs, if you give them garbage, are still going to give you garbage. So the more data really matters, what you stick into a system. And so what I want to show you now is basically a bunch of cool studies and what they're doing. So start with the more normal stuff that you've heard of. So this is through social media analysis. They took 1 million social media posts in a whole bunch of languages, and they were able to identify, here you can see based on the different sources, various mental health outcomes about a week before a human expert could do it based on the same data. So the LLMs were really good at analyzing the social media data. Here's another cool one. They took a bunch of different data, which is basically all your social interactions on your phone. This is obviously consented individuals. Behavioral data via Fitbit, so they had a wearable. And they did surveys to see how people were feeling. And then they tried to create a prediction system of mental health states using a very interesting AI model. They used recommender models, which is how Amazon knows people who like this also bought this other book, or Netflix, people who watch this one, right? So they used that on this kind of data and ended up doing really, really well. And so that was kind of synthesizing different data sources. Here's another one using voice data analysis. I think we heard some of this in other talks. And they were able to do pretty well looking at these types of data. Their system is called NeuroVibeNet because they like the vibes of the voice. And they synthesized both behavioral data and voice data and did pretty well. Now we're going to get a bit crazier. The next 2 or 3 are going to get a bit crazier. So this one, they wanted to know, does your behavior on your social media, right, when you're talking or when you're texting on your phone, is the interpretation of that behavior different based on what time of day it is and where you are? And so they integrated location data from the phone and created different models for how does Jane speak when she's at home in the morning, and when she's at work in the afternoon, and when she's at home in the afternoon, and when it's this and that. So they put a whole bunch of contextual awareness and created different models for each one. And they were able to create a much more accurate predictors of mental health state, because these things, signals mean different things in different settings, right? And if you say something when you wake up and you're eating breakfast, or you say the same thing at work, they could mean 2 radically different things. So the kind of context really was important. The other interesting thing here was, from a computer science perspective, in order to preserve privacy, they had to keep all these data sets separate. And so they used something called federated learning, for people who'd heard of that, which are these kind of distributed machine learning approaches. So if you're ever stuck with a problem that your data lives in different places and you can't bring it into one place, there are federated learning approaches, and they used one like that. I think we got a couple more here. So this one is pretty crazy. They looked at environmental determinants of mental health. So they looked at pollution data, weather data, temperature data, socioeconomic, where you are, how rich people are around you, all these things to try to see if they affected models. And they found, as expected, that your socio-demographic variables were more important than other things. But they also found, fascinatingly, that in certain cities, not in others, but in certain cities, high temperature days were very, very predictive of kind of bad mental health states. And it actually came up as significant. So very fascinating study. I think we got 2 more. This one, they looked at EEG data. Okay, so this is not as easy as using a phone, but if you want to wear an EEG cap, they found that your EEG could predict the response to specific antidepressant regimes. So if they need to give you some antidepressants, they could predict if it would work on you based on your EEG, right? And this was kind of a black box model. All right, are you ready for the craziest one? Here we go. AI-driven early mental health screening, analyzing selfies of pregnant women. Okay, this is where we've arrived. So what they were able to do is they basically took women, they point out that these are AI-generated images for the figure. So this is not any of the specific women who are involved in the study. I wanted to point that out. Okay, so what they did is they took a whole bunch of women participants. They had them take selfies with their phone as they would. It wasn't like a structured environment. Just take a selfie. They did a PHQ-4 evaluation to understand their mental state. And then they applied different computing techniques to try to interpret and predict mental state based on the selfie. Okay? And they didn't tell the women what to do during the selfie. They say, take a lot of selfies. Okay? They didn't say smile or don't smile. They just say, take a selfie. That was it. It wasn't like a passport photo where you had to do a structured thing. And they used 2 kind of approaches. One is called a convolutional neural net, which is often used to interpret video or images. And another one is called a VLMS, which is I think, video language model system. And the VLMS, which is one of these newer models, can actually work with 0-shot approaches and was able to predict to 77% accuracy the woman's mental health states based on their selfies, the unstructured selfies, which is pretty good, especially since some of them were smiling all the time, some of them weren't, so it was picking up on some small cues. But the reason I bring this example is that the data sets are also exploding. The types of data, the modalities are also exploding. It's not just that AI is really good and now we can do stuff. It's also that more and more data is being collected, more types of data. All right, you ready for the last one? This is the last part of the slide. This is just to show you how crazy these data people are getting. Okay. Leveraging LLMs to predict affective states via smartphone sensor features. So you're like, well, what are the sensors on a smartphone? You're not supposed to read all this. This is just, you're supposed to get, okay, there's a lot. So you think, well, what can a smartphone do? It can take a picture. It can maybe listen. It can monitor your texts, right? Well, it can do a lot more than that, right? You can monitor a whole bunch of different things. What is the ambient sound? How much are you moving the smartphone? How much are you switching? How quickly are you typing? How erratic is your typing? Everything you do on a smartphone can be analyzed many, many different ways. Here's a few dozen ways that they looked at it. Your applications, your battery, your keyboard, your locations, your messages, all that stuff, okay? So they took all this data on your phone and they tried to predict mental health states, and they used some sort of standard measure to actually survey the people. And they tried to do it with zero shot, which means we're not going to give you any training data. We're just going to get you to try to predict it, you, the AI. And they didn't do so well when they did zero shot answers. And you see basically in each row there is, let's say, inspired, right? And then you ask the person, how inspired are you? So you give a score 4 out of 5. And then the computer didn't know that, so the model said, well, they didn't use any social media applications or dating apps, and there were no emails, they were not attentive to these aspects of their, oh, sorry, that's attentive. There's no clear evidence that just the person was inspired during the week. They gave it a 1. Okay? This was the model before training. Then they gave the model some training data. So this is after 10 examples, called 10-shot learning. Okay? And you see, you don't have to go through there now, but the computer is basically, the model is making up a whole bunch of explanations. This is called chain of thought reasoning. It's explaining to you why it's thinking this. And the numbers match much more closely. And this is the learning curves, the kind of, you see the error bars going, the error going down, and the correlations going up. And here's the results. So this is, if you ever wondered, what does your phone think of you? Okay, here's the behind the scenes. And this is just ridiculous. So if you want to understand if someone is alert, you can see, are they unlocking their screen a lot and having high activity? Okay, that makes sense. Are they inspired? So for some reason, increased messaging in calls means that the person is inspired. I'm not sure if that's the best word. Determined, there's consistent typing and mobility. So you can actually look at the temporal patterns of how you type. Afraid, erratic screen usage and high ambient noise. I'm not sure that's the best predictor, but it worked numerically. Nervous, increased backspacing, frequent short typing bursts. Okay? So you can kind of feel on the keyboard the person's nervousness. Upset, reduced mobility, many missed calls. I'm not sure that's the best word. Hostile, abrupt typing patterns, fewer social interactions, right? So you can kind of interpret all this together. I don't know if this is, going to win a Nobel Prize, to put it lightly, but it's very, very interesting. And so while everyone is kind of focused today on the AI and the technology being used to analyze data, it's also important to keep an eye on the data being analyzed, because that's also exploding right now. We'll end with that. I really thank you for your time. Thanks for the invitation, and look forward to any questions you have.